Welcome, everyone. I would like to join you to the EHA ERN-EuroBloodNet Spotlight on Congenital Bone Marrow Failure Syndrome. Today is the first webinar of a two-part series. Today is webinar 1, which is titled The Advanced Diagnostic Approaches to Congenital Bone Marrow Failure Syndrome. As a reminder, this is a webinar series that's oriented towards health professionals, and it is the product of a long and ongoing collaboration with the European Hematology Association and ERN-EuroBloodNet, which has been in existence since 2022 and have been collaborating to deliver high-level educational programs aimed at healthcare professionals. So very briefly, just because we're already short on time, I would like to introduce our chairman, Professor Régis Peffault de Latour from the Hospital Saint-Louis in Paris, the speaker, Professor Thierry Leblanc from the Hospital Debré in Paris, Professor Lidye de Costa from the Hospital Kremlin-Bicêtre and also Hôpital Publique-Hôpitaux. And last but not least, Professor Carlo Dufour from the Institute Giannina, Gaslini, and Genoa. So with that introduction, I would like to hand the floor directly to Thierry, who will start with.
So I will have to do an introduction on inherited, better than congenital, inherited bone marrow failure syndromes. I have nothing to disclose. The plan of my presentation will be to describe the landscape of IBMF. The second part will be to how to distinguish acquired aplastic anemia from inherited bone marrow failure syndrome. And I will have a few words on somatic genetic rescue. So the landscape of IBMF is very large, and we have currently more and more disease. The perimeter varies widely depending on authors, but I think we have to focus on disease with overt bone marrow failure. That means aplastic anemia presentation or multiple cytopenias. The number of diseases is growing because of the progress in genetic, and as you know, we have a highly variable pathophysiology going from DNA repair to ribosomopathies. If you consider the IBMF, the age matters, obviously, but you may have a diagnosis of IBMF whatever the age, and actually, depending on age, you may have different disease. For instance, we will not have a diagnosis of Fanconi anemia with aplastic anemia in an infant. But in infant and toddlers, you may have omega-kystosis and some other syndromes. We have disease which affects mostly children, some other ones mostly ayahs, and also a disease which may be diagnosed in adults, specifically telomere disease, but also GBA, for instance, some rare subtypes of Fanconi anemia. Inheritance may be tricky, and we have more or less all the kind of inheritance, but you have to keep in mind that we may have de novo mutation. This is specifically the case for Mecum syndrome, for instance, for which most of the patients have a de novo mutation, but it's also the case in other diseases like DPA, with a majority of patients with no transmission. And more tricky for telomere disease, we have genes we may first describe as autosomic recessive disease, and now we have example of autosomic dominance inheritance. Extra hematological phenotype may be helpful, and some features are very suggestive of some IBMF, for instance, TUBS anomalies in Fanconi anemia and DBA, or nail dystrophy in telomere disease. So it's very important to have a full clinical and radiological checkup in any patient. But in some patients, the syndrome extrahematological phenotype may be absent or very subtle. For instance, for Fanconi anemia patient, tenar eminence hypertrophy, which is always asymmetric, is much more frequent than TUBS anomalies. And you have also to have in mind that the phenotype development varies over time. For instance, in Fanconi anemia, because of DNA instability, you have more and more caféole spots with age, and obviously it's also the case with telomere disease because of telomere shortening, and nail dystrophy and so on may be more and more obvious. So it's difficult in young children, it may be much more easy in older ones. So when to think to IBMF, in children we have to be quite systematic because any case of central cytopenia, including macrocytosis or aplastic anemia, may be suspect of inherited bone marrow failure syndrome, whatever you have or not congenital anomalies or extra-hematological phenotype. A more tricky situation is the patient or child with MDS or acute myelogenous leukemia, but with a special presentation with multilineage dysplasia, complex karyotype, monosomic karyotypes, and so on, which are not very frequent in children. And in some patients, you may have a diagnosis of Fanconi anemia or Schwarzman-Diamond syndrome, for instance, at the stage of leukemia with no previous diagnosis. So you have to keep an open mind about that. And at the best, you will do the diagnosis before any bone marrow failure syndrome. And this is very important, for instance, in Fanconi anemia, because obviously congenital anomalies are present at birth. At the time, blood counts are normal, or maybe you have only macrocytosis. In adult patients, we have more and more diagnoses currently because of genetics. So it may be an atypical erythroblastopenia, which turn out to be a DBA, actually. Very often, patients are diagnosed as MDS, but if you have a young patient, less than 50, let's say, with a normal karyotype, normal myeloid NGS, and a diagnosis of MDS, actually, in most of the cases, the correct diagnosis is IBMF. But in this patient, you may also have true MDS. And once again, it may be in a young patient with very severe dysplasias and very severe karyotype also. You have to think about IBMF in such cases. And lastly, you have to think about IBMF because you have a patient with unexpected cancer, for instance, head and neck squamous cell cancer in a patient without alcohol or tobacco exposure, or because of unexpected hematotoxicity of chemotherapy, and specifically in Fanconi anemia in DBA, disease which are associated with high risk of cancer. A good point is we have more and more diagnostic tools. We have some useful screening tests. I will speak about that. And we have also, for some disease, functional tests. The best well-known are chromosome breakage tests for Fanconi anemia or telomere length for telomere disease. We have also a big progress in genetics. So we have more and more genetic tests, more and more NGS, more and more disease on which can be diagnosed. So this is a good point for diagnosis, but we have also more and more atypical cases. And we have also a problem of validation of thus, and I think Lidye will speak about that. The second part of my talk is about how to distinguish IBMF versus acquired aplastic anemia. Obviously, it's very important in children, and we think that about 30% of children with aplastic anemia do have an IBMF, actually. So the main message is in IBMF, the bone marrow failure is progressive. So if you have, for instance, a child with normal blood counts 1 year before the diagnosis of aplastic anemia, you can be sure, more or less, that it's not IBMF, but acquired aplastic anemia. The problem is we have now an exception for that, is the SAMD9-9L syndrome, which may be very acute in the presentation. Obviously, you have to think to look for familial history, for consanguinity. You have to do a good clinical examination and some imaging. Fetal hemoglobin may be helpful, and IBMF, if is typically associated with a very high hemoglobin fetal, more than 10%, but we have a gray zone between 5 and 10%. PNH clone is very important and is absent in IBMF. And we have also other tools like 6P loss of heterozygosity. I suggest you to read this paper, a very good one. We have a quite number of patients, including children and adults, and they evaluate 3 different tools. And as you can see, for PNH clone, in acquired aplastic anemia, the sensitivity is about 50% of patients, and the specificity is 100% of patients. So for pediatrician, that means if you have a child with aplastic anemia and a PNH clone, you don't have to lose your time on a very extensive IBMF workup. You can say it's acquired aplastic anemia and give a proper treatment. And the last part of my talk, and it's very important to know, is the somatic genetic rescue events, which may be very frequent in a patient with IBMF. So you have to understand this is a somatic mutation, and if this mutation occurs in a stem cell, you may have a clonal hematopoiesis because of a correction of the phenotype. It may be a direct correction, a kind of spontaneous gene therapy, or an indirect connection involving another gene or locus. The best example maybe of this is this very nice story of 2 adult patients. They are twin sisters, and during pregnancy in one cell, there is a correction, so a somatic genetic rescue, a gene therapy, and the multiplication of the cell allow clonal hematopoiesis with some cell going from one sister to another, and at the end you have 2 adult patients with normal bone marrow function, no failure, because of the correction of one cell. And it is very important for you to have this in mind, and the take-home message for somatic genetic rescue are this kind of event may explain phenocopy. That means a patient with a typical clinical presentation, for instance, of Fanconi anemia, but normal blood counts during life. This may explain late diagnosis in adulthood, and this is an example of patient, Fanconi anemia patient, diagnosed at the age of 49 because of leukemia, but no previous bone marrow failure. This may also explain variability of expression in one very family, and we have very good example of that in telomere disease, with some patient having bone marrow failure and some other not. And you have to understand that if you want to do this kind of diagnosis, you have to work on extra hematological DNA, and the best way is to work on fibroblasts. Lastly, but maybe Lidye will discuss that, this kind of event may be very helpful to classify a class 3 variant, specifically, for instance, in 79L patient. In most of the genetic variants are class 3. So in conclusion, IBMF is really an evolving world. We have more and more disease, more and more atypical cases, including diagnosis in adult patients. We have more and more unexpected results from genetic study, and sometimes it's really a surprise. So I think IBMF must be well known by all hematologists and also oncologists. Thank you for your attention.
Thank you very much, Thierry. It was very informative, and you are perfectly on time. So we have 3 minutes to discuss, and even 5. I guess for us as adult physicians, the most difficult part is that we may miss some patients, and then there is terrible consequences regarding treatment with high toxicity. So the first question, in a way, will be until what age do you think we should still think about constitutional disorders? And And what are the main signs that should make you think absolutely to it for the physician that are having more than for patients older than 18?
I think there is really a limit of age because, for instance, in Fanconi anemia patient with somatic genetic rescue, and also in DBA without somatic genetic rescue, you may do a diagnosis at the age of 50, for instance. So it's very difficult to give a limit. It depends really on the clinical presentation. And I think you have to keep an open mind because, if you have, for example, a patient with MDS, but it's less than 50 and karyotype is normal and NGS, myroid NGS is normal. It's not MDS. It's only IBMF, which is good enough for the patient. The tricky part, once again, is that kind of disease you may have a presentation which look like MDS and also true MDS with clonal evolution. So I agree it's not always easy for adult patients, but you have to improve your knowledge about this disease. For example, the Fanconi anemia patient diagnosed in Saint-Louis is because it was in Hôpital Saint-Louis. And in Hôpital Saint-Louis, even adult hematologists do well-known Fanconi anemia. So they see a patient not very tall with clumps anomaly and myelogenous leukemia. They directly think about Fanconi anemia.
And in the same trend, there's these questions coming from the floor. In cases of delayed recovery after chemotherapy in adults, is there a clear cutoff that we should look for? And I think it's the same vein. I mean, it's not only toxicity. Should we think about it if we have some delay in recovery?
Yeah, sure. And it depends of the disease. For example, I have a patient with a DBA mutation, but no phenotype. And this patient was the mother of the patient with DBA. She had breast cancer, and during chemotherapy, she had unexpected need for red cell transfusion. And at the end, she's still anemic because after, in Fanconi anemia patient, the delay of recovery will be obvious in any toxic chemotherapy for bone marrow, and you may have additional toxicity if you use alkylating agents. And in that case, you will have both hematological toxicity, but also gastrointestinal toxicity and liver toxicity. So any kind of unexpected toxicity and specifically for MDS, cancer, and so on, you have to think about IBMF, underlying disease.
So now it's Carlo who is going to address the diagnostic challenges in this field. Carlo, thank you very much. The floor is yours.
I think that Thierry already very nicely introduced the general landscape of constitutional bone marrow failure. So this is my COIs. And this is what we're going to discuss. I would like simply point out on how difficult can be making diagnosis of FA, just presenting you a case. And then I will focus a little bit more on diagnostic challenges in telomere biology diseases and in a kind of new constitutional bone marrow failure, which is called DADA2. So that's for Fanconi. These are the findings from the Italian registry of FA, where you see that the median survival age is in the range of 29 years. But if you look at the composition of this population, you'll see that about 84% of these patients are aged above 18. 70% of the patients included in the Italian registry are transplanted and 30 are non-transplanted. And of these non-transplanted, about 1/3 is alive. That means that there's also a chance for adult hematologists to meet an adult FA patient either for diagnosis or for pre-transplant workup or for post-transplant surveillance monitoring. So this is something that I would like to highlight. Thierry already said this, and I will reinforce that age is not per se criteria for excluding an IFBM. So this is the case I would like to illustrate. This is a male, 32-year-old, which has a silent non-hematological personal history. he had a younger brother with mild pancytopenia. He was suffering of mild bilinear cytopenia from infancy, but this mild cytopenia was stable over time. He was diagnosed at age 26. He underwent a bone marrow aspiration that showed a reduced cellularity for age with no dysplastic features and no clonal abnormalities. Then COVID came. He had quite complicated outcome of this COVID, pericarditis and myocarditis, but at the age of 31, he received a formal diagnosis of FA with a mutation in FANG-G genes. And this mutation was also being identified in the brother, and it was also reconstituted the trio because the two parents were carriers of the same mutation that was found in the patient at the homozygous state. Then this young man was put in the monitoring plan we follow in our centers, which for this kind of cytopenia foresees a peripheral blood count every 3 months and a bone marrow aspiration every 6 to 8 months. He had the first bone marrow aspiration after diagnosis, which showed a kind of stable hypocellularity, which was associated to mild moderate cytopenia. No dysplastic features, no cytogenetic abnormality, but 8 months after this bone marrow, the patients incurred in an overwhelming AML, which led him to die due to multiple organ failure and cerebral hemorrhages. So this is just to tell you that you may have a late diagnosis in a disease that looks quite smoldering and stable that may suddenly change, turn into a very dramatic outcome, as the case of these patients. This is why we keep on following in our centers this kind of monitoring schedule that foresees for mild cytopenia with no cytogenetic abnormality, no signs of NAS and AML, FBC count every 3 months, and a bone marrow evaluation every 6 to 8 months. So I'll move now then to the telomere biology diseases. I don't want to spend many words on telling on what these diseases are, simply outlining that this disease in which about 70% of patients has mutation in 15 or plus genes included in the sheltering telomerase complex. This is a list of the potential genes. This is a disease which is very tricky because the inheritance can either be X-linked, autosomal dominant, or recessive. The biological hallmark is a remarkable shortening of the telomere, and the classical triad that we have been taught to learn at medical school, skin dyspigmentation, nail dystrophy, and leukoplakia, characterizing what was called keratosis congenita, is still ongoing, but you have to bear in mind that disease in his multifaceted appearance may have a very variable penetrance with a variable phenotype, including marrow failure and increased risk of tumors. To make things even more complicated in an already complicated scenario, recently it appeared that some sheltering variants generate telomere biology diseases by telomere instability without telomere shortening. So telomere shortening may not be always a hallmark of the disease. And this is the case of both mutations of biallelic CTC1 mutation and of other mutation that may act with different mechanisms. So basically for diagnosis of TBDs, you have to put together clinical features plus telomere length measurements plus genetics. I would like to focus a little bit on telomere biology diseases in adult. There's sure another diagnosis of this disease in this category of patients, and this is, of course, has an important impact for prognosis, surveillance, treatments, detection of complication, and appropriate family counseling. Particularly in the adult, it looks that the clinical phenotype is significantly different as compared to children and adolescents, because the autosomal dominance looks predominant. Initial manifestation sometimes starts after age 40 years, and after, as already highlighted, there is an oligo or monosymptomatic appearance, often lacking a skin phenotype. This is why I said that sometimes the classical triad is a kind of college textbook memory. In particular, you have to look at aplastic anemia or marrow failure, early onset of sporadic pulmonary fibrosis or family history for pulmonary fibrosis, unexplained liver diseases that might either be associated or not with an early onset of an head and neck squamous cell carcinomas. If you have one of these conditions, telomere length and genetic examination investigation are strongly recommended. This is what looks like in the adult, the appearance of TBDs. But you have to be careful because in the adult age, telomere, rather than very short, which means below the first percentile, is more frequently short, which means between the first and the 10th percentile. And the other thing is that this is an important contribution provided by the group of Fabian Bayer in Aachen and Tim Brummendorf in Aachen. In age above 40 years, it looks like that more than a percentile shortage is the absolute shortage that makes the difference. And particularly, you have to look at a value which is lower than 6.5 kilobase that looks more specific than centile in the measurements of telomere length. For making diagnosis of TBD, which, as I said before, looks very much complicated, there are tools available. This is one which comes from the American colleagues that, based on the bone marrow failure, MDS occurrence, interstitial lung disease occurrence, head and neck and squamous cell carcinoma, unexplained liver disease, and triad features. Triad means mucocutaneous alteration and those characteristics of the DKC may or may not direct the doctors, the investigators, towards the measurements of telomere length that should be done in fish. Then the colleagues in Aachen, Tim Brummendorf and Fabian Bayer, elaborated another point-based algorithm, which, taking in account of a number of items, mutations, degree of telomere shortening, family history, etc., identified 3 potential categories of proven, probable, and suspected only telomere biology diseases. This is important, this is nice, but there's still probably need for validation on a larger cohort. AI, in artificial intelligence with machine learning tool, may be somehow supportive. In our group, we conducted a supervised analysis, which means that we set a driver in the distribution and the analysis of the data, and this driver was genetic tested. And with this system, we identified 17.2% of patients who were unidentified diagnosis, and we locate them into the TBD categories. But more important, we were able to recategorize 82.7% of patients who had undefined diagnosis to other non-TBD inherited bone marrow failure diseases. Then we conducted a non-supervised analysis, which means that we took all the data, clinical and molecular data, and we put them together to see whether they cluster in some way. And we identified 4 clusters, 1, 2, 3, and 4. And we noticed that in cluster 1 and 2, there was a clear prevalence of molecularly defined TBDs. And importantly, there was a kind of concordance between these 2 systems, supervised and supervised analysis, because all patients diagnosed as TBD by supervised analysis fell in these 2 clusters, 1 and 2. And we were also able to locate in this cluster also 5 out of 16 patients who had the VUS on a TBD genes. So this can be a tool, but of course, also in this particular case, we need to validate this AI system on a larger cohort of patients. The final part of my talk will be focused on the other 2. The other 2 is a deficiency of other 2, which is a molecule which is expressed on myeloid cells. It acts like a cytokine-like activity, downregulation, inflammation. When other 2 is deficient, macrophages gets polarized to M1 phenotype, which is an inflammatory phenotype, which also implies the activation of neutrophils. Other 2 deficiency generates a multifaceted disorder with autoinflammation, vasculopathy, immune deficiency, autoimmune phenomenon, and marrow failure. These are the findings of the Italian registry of the data 2, kindly provided by the our hematologist colleagues in Gaslini. You see that you may have also mucocutaneous alteration, lymphoid, hematological, ocular, cardiological, GI manifestations. As for the hematology, you may have all types of cytopenia, mono, bi, and trilinear cytopenia. As for immunology, the most relevant features are diffuse lymphadenopathy, low IgG levels, low switched memory B cells, low memory T cells, and low natural killer cells. These are the general characteristics, but not, of course, you cannot find them always in all patients. So differential diagnosis is with the ALPS and other immune cytopenia. Like this case report, this is a patient observed in our centers, is a 26-year-old lady which was referred at our centers after an 18-year-old history of cytopenia, autoimmune hemolytic anemia, and PRCA. So ALPS and other immune cytopenias can mask another deficiency. The same applies to PRCA and to the Diamond-Blackfan syndrome, which is, you know, an acquired constitutional pure red cell aplastic anemia. Diagnosis of this disease is possible by measuring the plasma activity of the enzyme that needs confirmation with the genetic testing. Be aware that in the genetic evaluation of this disease, copy number variation is an issue. So sometimes genetic testing is not conclusive, and so you have to carry the MILPA for detecting on whether the disease is related to copy number variation rather than specific single mutations. I think that this is my last slides. As a take-home, as already highlighted in part by Thierry, it looks like that IBMF are very difficult to diagnose. There is a number of newcomers that makes the scenario even more complicated and crowded. Age per se is not a diagnostic criteria and is not a diagnostic exclusion criteria. Of course, genetics improve diagnostic accuracy, but may not be conclusive, needs to be conjugated with the functional testing. And you need to complement genetic with functional testing and clinical finding. And in this specific task, AI may be of some support. Thank you for your attention.
Thanks very much, Carlo. Again, an excellent talk, and I'm sure that everybody appreciated. There is something that is absolutely fundamental from your talk, and that's something that sometimes is missed, is the place of immune deficiency inherited disorders. In other words, the abnormalities of the immune system associated with constitutional inherited disorders. And I think that you may want to elaborate, because most of the time we're focusing on physical accepts on of course, the patients itself, the blood counts, but we are forgetting the immune part. And that's really something informative that we should not keep on the side, right?
Yeah, I think that's a good comment, Régis. Thank you for having that highlighted that. It's relevant. We have investigated that in more depth in our center. And we have this is a paper from Maurizio Miano from our team. We have seen up to 17.2% of patients categorized with marrow failure who did have an autoimmune markers and also carried pathogenic variants for immune dysregulation or immune deficiency. So this is something that you have to take in account. Also bearing in mind that, for instance, in telomere biology diseases, autoimmune phenomena or immune dysregulation phenomena are part of the feature. So, and they can be something which is related to the telomere dysfunction. So this is why we suggested to include in the diagnostic workup of any marrow failure, either acquired or constitutional, the immunological screening, immunoglobulin, T and B and NK subpopulations, and sometimes also other immunological markers as autoimmune antibodies.
And there is another question coming from the floor. How can I approach a patient with isolated neutropenia?
Actually, I can tell you that we have now guidelines. We have guidelines on management and or treatment of acquired and constitutional neutropenia. These are carried out by a combined action of European Hematology Association, the scientific working groups on granulocytes constitutional marrow failure, and EU-NOT endocrine actions. They're published on Hemisphere. 2023, those related to the diagnostic and management, and recently 2025, those related to treatments. So basically, again, you have a number of testing starting from genetics, and then you also consider the immune dysregulation in the background of the isolated neutropenia. This is kind of short question because that detailed question would require far longer time.
No, definitely. So in the last 1 minute that we have, is there any centralization in Italy? How do you manage those patients? Because I guess the test cannot be done everywhere.
Yes, we centralize the test either for immune neutropenias, the anti-neutrophil antibodies, which are kind of screening tests, are not so specific and sensitive, honestly.
No, I was speaking about, constitutional BMF.
Okay, sorry about that. Yeah. We do centralize. We have a panel with 162 genes. We carry out regularly for diagnosis of these tests. We also perform testing like chromosomal fragility test and other tests which are required for validating VUS. And in our centers, we offer these facilities for the diagnosis of inherited bone marrow failures.
Thank you very much. This is a very nice transition to Lidye, who is going to speak about NGS and NGS applications for BMF disorders diagnosis. Lidye, thank you very much.
I'm going to talk about the application of next generation sequencing in inherited bone marrow failure. And I'm very pleased to be here. I have no conflicts of interest to declare. So what is the next generation sequencing? Actually, it's not anymore so next, since it has been discovered in 2008, but we keep this name. It was definitely and really into our practice in hospital in 2015, at least in France, and in my labs in 2016-17. In order to do next generation sequencing, you need to have sequencing engine and softwares that will be able to analyze millions to billions of sequencing reactions from the human genome and simultaneously. So you can imagine the large increase in the amount of information that we can get. It saves time and it's less expensive. Meanwhile, since we are doing more and more sequencing, it's not that less expensive compared to before. But the cost of the sequence is very cheap now. So in order to do that, you need to still have the sequencing engine and software, but there are various ones, but they all share some steps. And in order to do NGS, you need first to do a library to build. You need to perform the sequencing, and you need to have a lot of software which allow the reading, the analysis of all the data. So we usually all using the capture sequencing technique. So what is that? It's actually at the first glance, you will see all the candies. So meaning that it's the complete, we say that it's the complete genome. And during the NGS, you will be able to screen 24 to 96 patients in the same time. So you can imagine how it can be fast. And at the first time, you need to collect the DNA, to extract DNA. And after that, you will fragment the DNA in small pieces from the same patient. And you will label the DNA with an index. It's like a barcode in order to identify your patient between the other one. And after that, we need we are using the capture probe. So from this total candies, you want only the watermelons one. So it's like your library. And in our case, it's 104 genes in our library in order to collect the information about the disease that we care about, and in particular, Diamond-Blackfan anemia. So the sequencing capture technique is like you want to target the DNA region of specific interest in order to, after that, to get the information about what you want. So just here some examples. So the result came like that from our software that we are using. So it's all the line, it's all the same sequence that have been read, and usually the engine is able to read more than 100 times the same sequence. And in order to pass our quality control, you need to find the same mutation at least 30 times in 30 reads to be able to provide you a datasheet result. So here is a homozygous CAA duplication. Here it's a CG and heterozygous one because you've got G and you've got also C sequence. And here it's just an intronic variation. So just an example, but just to show you that before to provide you some data, we need to pass all the data and all the screening information and to pass to all the quality control. Then we need to make some annotation of the allelic variation, and we are using the recommendation from the American College of Molecular Genetics and AMP. And you need to know also that, at least in France, but I think it's the same in other countries, the final characterization of the mutation is that the only assessment and responsibility of the biologist or the geneticist. You need to know also that the mutation analysis is always performed at a special time and depend on our knowledge at this time, meaning that sometimes we cannot provide a result at this time, but when we go back to the sequence, we can provide you some information that we couldn't get before. We need to also label the allelic variation we found depending on their pathogenicity, and it's order to provide you some information saying that, okay, this mutation has got a very strong support for pathogenicity, or strong or moderate or just a supporting criterion. We got the same for benign mutation. And at the end, we should be able to classify the identified mutation in one of the 5 classes. So you don't see the class 1, which is benign variant, class 2, likely benign variant, and class 3. This one we don't like so much, but in fact, in inherited bone marrow failure, most of the mutations are unknown significance variant. It means that we don't know if they are involved or not, because it's a rare, it's usually a rare variant and sometimes missense mutation. So in order to say that, okay, this one is involved in your patient and it's responsible for the pathogenicity, we need to do some additional functional experiment that Thierry and Carlo talked to you before. And usually it could be like perform some erythroid culture, or it could be like performing a ribosomal RNA maturation study on northern blot. It could be performing a BV cell line, or looking at the mutation in the fibroblast. So it's very convenient in order to make sure that the patient carry the mutation also at the in his germinal or germinal cells. And it's not a somatic one. It's also very important for somatic variation proof. We can have some help also from the bibliography, from family type segregation. And so all is very helpful to make sure that a non-significance variant could be at least a class 3+, or go to the class 4 likely pathogenic variant, or class 5 pathogenic variant. So usually we are very confident to provide some results for class 4 and class 5, and not very confident for class 3. Otherwise, we need find some proof by functional experiment. So some example from some gene from DBA, but just to show you the importance of the functional experiment. This missense mutation in RPS19, so you need to be careful about the missense mutation, because sometimes it's just polymorphic allelic variation, but in that case, our lab and other prove definitely that this variation is related to DBA, using some erythroid cell culture or a BV cell line, same with RPS26 variation here. So it's a missense, but we prove that it's definitely a pathogenous one, so class 5. For this one, it's class 4, likely pathogenic variant, because it's a del-1 insertion mutation, and it's probably leading to that protein, and so is involved probably involved in the disease. So this is what we are doing for DBA mutation screening, but at least in fact, I think you can do that for each bone marrow failure. First, we are performing the targeted NGS on our specific genes. If we found a mutation and we prove that it's the one involved, we stop there. If we don't find the mutation involved, we go for the large deletion screening, and you can use CGS array, you can use MLPA. in order to look at the CNV. And actually in DBA, 20% of the patient carry a large deletion that is not so. You should find them on the targeted, but definitely it's easier to prove on another technique. If we don't find a mutation, a large deletion, neither mutation per targeting NGS, we go for exome or genome sequencing. And in France, we are using in the north part of France Sequoia platform, and in the south part Origin platform. So doing that for DBA genotype, 25% of the patient carry a mutation in RPS19. Then you've got RPL5, RPS26, RPL11, RPS35A, RPS10, 34, and RPS17. So 20% of the patient carry a large deletion in one of the gene. And with all of that, you've got already 75% of the DBA patient that are characterized. Then you've got very rare patient mutated in one of these ribosomal protein gene. And at the end, there are some genes that are not RP gene at TSR2, but TSR2 is still related to ribosome biogenesis. There are some genes that are not RP gene and not related to ribosome biogenesis, like GATA2, erythropoietin, or P53, and they are defined with DBA-like cases. At the end, 20% of patients, and actually it's the same for quite all the inherited bone marrow failure or all constitutional disease, there are still 20% of patients that are not a genotype. It could be a mutation that could be accessible only on whole genome sequencing. It could be some new candidate gene, or it could be a misclassified patient as well. We recently identified a new gene in DBA. It's ETR3, so it's a chaperone of RPL5, and you need to have a good ETR3 to make the translation correctly of RPL5, and you need to have a good ETR3 to import RPL5 into the nucleolus to be assembled to the ribosome. So it's definitely a real DBA disease, and it's associated with a ribosomal RNA maturation defect. It has been found by exome sequencing into the EuroDBA consortium, first in the Netherlands on this family, then in Turkey and in France, with this patient who is heterozygous composite mutation in ETR3 gene. And it's probably because of the patient inherited the mutation, one of the father and one of the mother, and it's not a consanguineous one, but it's less severe compared to the other one. The other one are homozygous one, and in addition to anemia and short stature, they got brachydactyly and intellectual disabilities. Then you've got some DBA-like and borderline DBA cases. They are related to GATA1, erythropoietin, and TP53 gene. So in that case, there is an erythroblastopenia, but there is no defect in ribosomal RNA maturation, which is the functional test that proves that you really have a DBA. So since this gene, we recently identified also RPL17, RPL26, in addition to the previous gene that we identified. So actually, it has been pointed before that molecular diagnosis actually changed the definition of the disease, and for DBA, it was really the case, but it's also the case for the other bone marrow failure. And now we are talking about DBA syndrome. So this is really, the sum of the DBA, and DBA is defined by the typical erythroblastopenia related to a RP gene or a gene which is involved in a ribosome biogenesis. So TSR2 and ETR3, and in that case, there is a ribosomal defect. There is a defect in the ribosomal RNA maturation on the nasal blood or on the new technique. And after that, you've got the DBA-like related to P53 EPO mutation. Apart, and Carlo talked about this syndrome, the ADA2 deficiency, but it was before related to DBA because in some patients, they exhibit erythroblastopenia, and actually in our registry, we've got 3 patients. They were misclassified as DBA, but it was COCR1 when we screen the molecular biology. And then GATA1 gene, actually it's a part because in addition to hypoplastic anemia, you've got dyserythropoiesis, dysmegakaryopoiesis, and now it's even more complicated because you've got some DBA-like who do not expect anemia, but they are related to a ribosomal protein defect. So they are not in the DBA registry. They are apart, but it's still in the DBA syndrome, like a patient mutated in RPS 23 or RPL 13. So for the take-home message in general and in all the disease and also in inherited bone marrow failure, targeting NGS, whole exome sequencing, whole genome sequencing will revolutionize the genetics because now we are screening at the same time a large amount of gene. The molecular diagnosis is easier, is faster. It should be cheaper, but actually the sequence is cheaper. But since we are screening more and more patients, it's also very expensive. And for the DBA in particular, the DBA molecular diagnosis with NGS is now easier compared to the 2020s. We can screen all the gene at once. It's easier for genetic counseling because we go faster to the screen and after that to the parents and relatives. We can perform prenatal diagnosis and pre-implantation diagnosis easily and more easier actually. And DBA definition more and more complex based on molecular diagnosis. And now we are talking about DBA syndrome. And actually there is a large importance of the functional tests to validate the insignificance variation in DBA, but also in all the bone marrow failure. And I will stop here. Thank you so much.
Thank you very much, Lidye. I'm very impressed because all you three gave wonderful talks. We are perfectly on time. Those are very difficult topics. I mean, that's really great. Something that we did not address possibly is the organization that we have in France with those two platforms for genetic diagnosis, and perhaps the time between diagnosis and disease identification. So in other words, how are we able to make progress? Because, I mean, for some of the disease, it's not very, I would say, not very severe or very painful or terrible for the patients if you don't have the diagnosis straightforward. But for others, like Fanconi and so on, it's really, really something we should do quickly. So do you think we could make some progress on it? Is the platforms improved it? If we should send to only reference centers, try to homogenize? I mean, as it's in France, what do you think?
I think that, so if you talk about performing the whole genome sequencing right away, I think it's very difficult right now. For sure, it will provide you more information and straight away. And if you don't find a mutation in the disease that you think about, you will go faster to the other one. But still, it's very complicated analysis, and I'm the only one here, but for talking to Caroline and every geneticist, it took us like one afternoon to check one patient if you perform whole genome sequencing to make sure, and because we are dealing also for the more difficult one, because when we go for the whole genome sequencing, at least in France, is not the first step. So it takes a lot of time to analyze whole genome sequencing. So perhaps faster will be to perform still the NGS in the easiest way. Actually, I don't know if it works, but in our hospital in Bicêtre, we decided to make a library of 700 genes. So to make easier and faster the sequencing, and doing that, we hope that we can sequence 400 patients per month, not only DBA for sure, and it will be the complete patient that comes to our hospital for constitutional molecular screening. So the library has been constituted, and we didn't run right away a library right now, but perhaps it will be faster to do that, at least for the organization of the platform. And you're right, I think it's more easy to centralize, to make sure that there are not a lot of, and we saw that actually for not for DBA or for, I think for the bone marrow failure, it's quite, at least in France, it's quite now established, you know, But in Bicêtre, we are doing DBA, and after that, in Jean Soulier's lab, they are doing the other bone marrow failure, and I think that in Caroline, she's doing this keratosis. But we saw that for the red cell membrane disorder, and now everyone can do the NGS, and actually we are wasting a lot of time because since everyone can do that, after that they come to us to see if the mutation they found is pathogenous or not, and we are losing a lot of time for that. So I think to make sure that it's faster is to do only in a few platforms. I think still next targeting NGS will be faster compared to whole genome. And after that, the deal is to go faster to whole genome when we didn't find something in NGS.
Thank you very much, Lidye. Just to conclude, I think that we as physicians see how it's difficult when you go for gene testing, NGS, whole exome, and so on. So how important it is to identify the good patients that should benefit from it. So we have a kind of algorithm in France. I think it's important for kids. I may imagine that we are testing for everybody because in kids, when you have bone marrow failure disorders, there is a high chance to have a constitutional disorder, even if it's 20% versus 80% acquired. This 20% is very important to eliminate because there is no way to do some immunosuppressive treatment in that kind of patients. But for adult patients, what we are doing at the moment is really to deserve this gene panel or the whole exome for very specific patients. If you have an acute BMF, something that rise up in 6 months without any history in the family, something very acute, isolated. If you don't have any family history, you have a physical exam that is perfectly normal. It's not necessary to go to this gene panel and whole exome and so on, because you're going to lose time, not only to treat the patients, but also for biologists, for an useless test that might be useful for others, and especially kids. And the last thing, and then I will, the concluding words for the PNH clone, we have now some biologists that are very experts in PNH, and if you have a PNH clone, it's very rare to have the association with PNH and congenital disorders. Very, very rare. If you have PNH, it's mostly acquired. And it's something that makes you also gain some time not doing some gene tests in those patients. So that will be my final words. Thanks a lot. Thank you very much for our speakers. The talks were outstanding. We're on time. Thank you very much for all the participants.